Hello and welcome. Today, we're diving deep into a serious kidney disease called Crescentic glomerulonephritis. This condition, also known as rapidly progressive glomerulonephritis or RPGN, is characterized by a rapid decline in kidney function and the formation of distinctive crescent-shaped structures within the glomeruli, the kidney's filtering units. Understanding this disease is crucial for timely diagnosis and effective management. So, what causes Crescentic glomerulonephritis? The causes are varied and can be broadly classified into immune-mediated and non-immune-mediated mechanisms. The most common immune-mediated causes involve antibodies attacking the glomeruli. This can occur in several ways. Firstly, anti-glomerular basement membrane, or anti-GBM disease, where antibodies directly target the basement membrane of the glomerulus. Secondly, immune complex-mediated disease, where immune complexes deposit in the glomeruli, triggering inflammation. This can occur in conditions like lupus nephritis, ague nephropathy, and post-infectious glomerulonephritis. Thirdly, post-immune glomerulonephritis, where there are few or no immune complexes present, but anti-neutrophil cytoplasmic antibodies, or ANCA, are present, leading to inflammation. Less common causes include drug reactions, infections, and in some cases, the etiology remains unknown, classified as idiopathic Crescentic glomerulonephritis. Furthermore, certain systemic conditions such as granulomatosis with polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis often present with Crescentic glomerulonephritis. Let's break down the pathophysiology. The key event is injury to the glomerular capillaries. This injury allows proteins, including fibrinogen, to leak into Bowman's space, the space surrounding the glomerulus. The leaked fibrinogen then stimulates the proliferation of parietal epithelial cells, which line Bowman's capsule. These proliferating cells, along with infiltrating monocytes and macrophages, organize into a crescent-shaped structure that compresses and eventually obliterates the glomerular tuft. This crescent formation obstructs the normal filtration process, leading to a rapid decline in glomerular filtration rate, or GFR, and subsequent kidney failure. The inflammation and scarring within the glomeruli further contribute to the loss of kidney function. Ultimately, if untreated, this progressive damage leads to end-stage renal disease. Understanding the epidemiology of Crescentic glomerulonephritis is important for public health and resource allocation. The incidence varies globally but is generally considered rare. It affects individuals of all ages, though some types are more common in certain age groups. For example, anti-GBM disease often affects younger adults and older individuals, while ANCA-associated vasculitis is more common in older adults. There are no significant differences in incidence between males and females. Geographical location can play a role, as certain regions may have a higher prevalence of specific associated conditions, such as infections or autoimmune diseases. The disease is generally considered rare, occurring in about 1.5 to 5 per million people each year. The signs and symptoms of Crescentic glomerulonephritis can develop rapidly, often over days or weeks. Common symptoms include hematuria, or blood in the urine, or protein in the urine, edema, or swelling, particularly in the legs, ankles, and around the eyes, hypertension, or high blood pressure and oliguria or reduced urine output. Patients may also experience general symptoms such as fatigue, malaise, loss of appetite, and weight loss. In some cases, the disease may present with systemic symptoms related to the underlying cause, such as joint pain, skin rashes, or respiratory problems in patients with vasculitis or systemic lupus erythematosus. Diagnosing Crescentic glomerulonephritis requires a comprehensive approach. The diagnostic process usually starts with blood and urine tests to assess kidney function and identify any abnormalities. A urinalysis can detect the presence of blood protein and cellular casts, which are cylindrical structures formed in the kidney tubules. Blood tests, including serum creatinine and blood urea nitrogen, are used to assess kidney function. Immunological tests such as anti-GBM antibody assays and ANCA testing are crucial for identifying the underlying cause. The gold standard for diagnosis is a kidney biopsy, where a small sample of kidney tissue is examined under a microscope. The biopsy reveals the characteristic crescent formation in the glomeruli and helps determine the specific type of glomerulonephritis. Additional imaging studies, such as ultrasound or CT scans, may be performed to rule out other causes of kidney dysfunction. Crescentic glomerulonephritis can be classified based on the underlying cause and immunofluorescence findings on kidney biopsy. The most common classification scheme includes three main types: type I, or anti-GBM disease, characterized by linear deposition of IgE along the glomerular basement membrane; type II, or immune, complex-mediated disease, characterized by granular deposition of immune complexes within the glomeruli; and type C, or post-immune glomerulonephritis, characterized by the absence of significant immune complex deposition. but frequently associated with ANCA. Understanding the specific type is critical for guiding treatment and predicting prognosis. Treatment for crescentic glomerulonephritis is aimed at suppressing the immune system and reducing inflammation to preserve kidney function. The mainstay of treatment is immunosuppressive therapy, which typically includes high-dose corticosteroids, such as prednisone or methylprednisolone, often combined with other immunosuppressant drugs, such as cyclophosphamide or rituximab. Plasmapheresis, a procedure that removes antibodies from the blood, may be used in cases of anti-GBM disease or severe disease activity. Supportive care, including blood pressure control with medications like ACE inhibitors or ARBs, fluid management, and dietary modifications is also essential. In advanced cases, when kidney failure has occurred, dialysis or kidney transplantation may be necessary. Currently, there are no definitive ways to prevent crescentic glomerulonephritis, as the underlying causes are often complex and not fully understood. However, managing risk factors for associated conditions may help reduce the likelihood of developing the disease. For example, avoiding smoking, managing autoimmune diseases effectively, and promptly treating infections may be beneficial. Regular monitoring of kidney function is recommended for individuals at risk, such as those with a family history of kidney disease or those with autoimmune disorders. The prognosis of crescentic glomerulonephritis varies depending on the underlying cause, severity of disease, and response to treatment. Early diagnosis and prompt treatment are crucial for improving outcomes. With aggressive immunosuppressive therapy, some patients can achieve remission and preserve kidney function. However, many patients still progress to end-stage renal disease and require dialysis or kidney transplantation. Recent research has focused on developing more targeted therapies and improving our understanding of the disease's underlying mechanisms. Clinical trials are exploring the use of novel immunosuppressant drugs and biological agents to improve outcomes and reduce the side effects of treatment. Additionally, research into biomarkers that can predict disease progression and response to therapy is ongoing. Further understanding of the pathophysiology of the disease may lead to more targeted treatment options.